very exciting talk. So we have a few minutes for a question and answer with our speakers. So Dr. van der Leun, Dr. Legreca, and Dr. Brito have joined us. We'll open it up for the audience first. And for our virtual online audience, please use the chat box to put in any questions that you have. Do we have any questions from the audience? All right, until we get some questions, I have a few. So Dr. van der Leun, I was so happy to see the distinction in the AUS plus category to nuclear atypia and AUS other, because as you mentioned, the nuclear atypia does have a higher range of malignancy. Was completely was it an option or a discussion of making those two categories completely separate? Was that, or what do you think? What do you think of that? Do you think we're likely to see that in future editions as well, just because of, again, the different kind of pathology, the different tumors we get from those categories, and just the different range of malignancy?
Yeah, that's a wonderful question. Again, thanks for the invitation to be here today with everyone. Yeah, so there clearly is a stratification of risk within the AUS category. So the nuclear atypia has a higher risk of malignancy, tends to have a little bit more of the BRAF type tumors, whereas the architectural atypia or the other AUS other, has the lower risk of malignancy, more of the RAS-like mutations kind of are found in there. And so, yeah, so the question is, as we gather more experience, now that we formally stratified it into two distinct subcategories of AUS, what are we going to do with that going forward? What is the threshold between an AUS with nuclear atypia and suspicious for malignancy? And on the other side, what is the appropriate threshold, between benign and AUS other, right? And so I think that we need to get a little bit better concordance and experience with that, as Dr. Brito talked about. There is subjectivity in evaluation of these FNAs, and so hopefully by very clearly outline, what belongs in each category and what are the illustrative cytomorphologic features that belong in each, we can tighten up in the cytopathology community that diagnostic accuracy. But then, yes, also going forward, should these be managed separately? And if they should be managed separately, does it warrant a splitting of into two distinct categories as opposed to subcategories within a category? Yeah, great question.
Thank you. Yeah. And so, kind of going on the same lines, Dr. Legreca, when molecular testing isn't available for these indeterminate nodules or not covered by insurance or whatever, what is, and the question is open for all our speakers. So what is generally, your approach? So here in the Middle East or in our part of the world, so molecular testing is still kind of limited in terms of cytology. And so we don't have it readily available, at least in in my institution, we don't. And so what's generally your approach to that when indeterminate cytology and molecular testing isn't available?
Yeah, thank you. Thank you for this invitation. We go to the old-fashioned way of repeating the biopsy after, sometimes 3 months. Yeah, right now here in the US, almost every patient has access to that because the insurance companies, really the out-of-pocket obligation is really low, even if you don't have insurance. So yeah, it's a different world here. So we do repeat the FNA rarely. Most of the time it's just for patients who don't have insurance, the out-of-pocket obligation is very low. So yeah.
Yeah, we hope with the new guidelines coming out later this year or early next year, and more maybe push for molecular testing, it will also be more readily available. I don't know, Dr. Brito, do you have anything to add?
Yeah, no, it's interesting. Can you hear me well?
Yes.
So at Mayo Clinic Rochester, we actually don't do much molecular testing. And has been mostly driven by, I think, our cytopathologists are trained probably in the school of really not using many atypia, for instance, or not using a lot of the tests that 3 to to some extent, so they tend to go with either benign or other suspicious diagnosis. And to some extent, that facilitates our decision making because we tend to go with diagnostic lobectomy more of the time. And the other part that has another reason why we don't use that much is that our internal projects that check the accuracy of the molecular testing actually have shown very good performance in our setting. Again, it speaks to the culture. It speaks to also the people that you work with, the pathologists, cytopathologists. So that is if something of importance here is each institution is kind of each environment in which this molecular test need to be validated to some extent. So for us, it has not worked that well.
All right, thank you. We're facing a very similar issue given that our patient populations are different as well from those populations where it's been validated on. I think
Audience, we have one question here. Can you ask?
Yeah, go ahead, Hadi, please. We cannot hear you well at all.
Can you hear me now?
Yeah.
Okay, great. Thank you very much for those great presentation. Oh, looks like it's going to be changed. Okay, so my question is relates to the molecular testing and thyroid nodules, and I think the difficulty that many physicians and patients have, and I'm going to ask you the question as if I was a patient. When I spend $3,000 or so on this test, would you be able to tell me if this nodule was 100% benign or 100% malignant? Or there's going to be a little bit of stuff here or there, because I don't see 100% there. So because this is the question that will come up.
Right. For the so these tests are very good as rule-out tests. So if that's why the predictive value is so high. I hear my echo here, but so. Can they hear my answer though? Yeah, okay. So a very high negative predictive value with both tests have close to 100. If the test comes back negative, the chances of having malignancies are very low. Goes back to a benign cytology rate, less than 3%. On the other side, the positive predictive value for both tests is around 60%. Let's set up an average there. Thyroid performs slightly better than Afirma. That means that a lot of the benign results are not going to be benign pathology in the end. So the reason for that is because a lot of the mutations that are seen could also be seen on benign disease. So a lot of times we tell the patients, yes, the test has 60% chance of malignancy. It said at least 40% of those cases are going to be negative for malignancy, and this patient's going to have a lobectomy anyways. So again, it's a very good rule-out test, not so much as a rule-in test. So rule-out rate is almost 100%. Rule-in, it's about 60% if we average both tests. So when the test comes back positive and it's 60%, 70%, then there's a high chance of still finding benign disease, depending on what's the rate of malignancy that the combination of mutation found in the test. So they're not 100% tests. They're very good rule out, not so much as rule in. I'm not sure if that was clear. Yeah.
Yeah, thank you. Yeah, I think if the patient prefers surgery, let's say, one way or the other, then the rule, the role of the test becomes a little bit like if you know that patient is probably likely to pick surgery, then the role of the test.
It's almost like an individualized conversation with the patient. I mean, some tumors are more than 4 centimeters and they are very high suspicious on the sonographic pattern, those indeterminate nodules with high HA-Tregs sonographic pattern turn out to be malignant most of the cases. So it's a combination of things, and offer that to the patient. Yeah, but no, they're not 100% test by any means.
Tanya, I have a question.
Yes, I think we have another
Actually,
question.
two
So
short
Dr.
questions.
Viana.
One is about the US again. I have seen people doing core biopsy after the first one, and they believe that the yield will be much better. I want to know your experience about this. And the other question about the use of AI, is it already available commercially and the machines available in the United States? Because we haven't seen it. This is here in the part of this world.
Yeah, I can touch base on the first part of the question. With AUS, the indeterminate categories are always the most controversial. And one thing that I did want to mention is that if you look at the old literature talking about if you don't use molecular testing, if you look at the older literature, when the first edition of the test that first came out, really it's about half the time on repeat FNA that you get a more definitive diagnosis of benign or suspicious malignant, that can drive clinical decision making. So there certainly is utility in repeating the FNA. From an alternative diagnostic standpoint, there are some practices that go to core biopsy of thyroid needles, thyroid nodules. We really don't use that here in Boston all that much. I think that the utility might be to have a little bit more of an intact architecture from a core needle biopsy. But again, if it's an AUS other, so if you have architectural atypia and you're worried about, could this be a follicular neoplasm, follicular adenoma, follicular carcinoma, again, you're not going to be able to detect that capsular invasion or vascular invasion on a core biopsy more likely than not. And so really, I personally have found limited utility in the core biopsy. I think that there is certainly utility in the repeat biopsy. And again, it also depends on the quality of the FNA. Sometimes if it's very paucicellular, you might be able to get more material with a core biopsy. So I think it's really what your local practice, your pathology department, your pathologist, your cytopathologist are comfortable with interpreting, and where they feel they can give you the most information. And then I'll hand it off for the AI question.
Yes, no, thank you. Thank you for the question. So it's very limited what we have right now in United States in regards to products that are available for practice. So I presented a couple of them. They had been FDA approved, so they are ready in terms of use in practice. But again, the challenge is to what extent they are useful. So many of the things that the people develop for the AI is mostly driven by there is data, there is abundance of data. We do something, let's present a product. But the pipeline should come from what is needed in the practice. How can this actually improve the practice, and then develop something that really helps clinicians and patients, in these kind of decisions. So until now, I still don't find something that is clearly useful. But yes, there are already some AI products in Thyroid available in the United States, FDA approved. But to reality, I didn't actually use any of those tools yet.
Thank you. I think we have time for maybe one more question. We'll take an online question. And this is from Dr. Khalid Farouqi. He is asking whether you've seen, or there are any studies that show that there are any changes in molecular alterations in thyroid nodules for people who have been on chemotherapy or immune checkpoint inhibitors, or other targeted therapies for other cancers, not thyroid cancer. Would that, you think, change the landscape of molecular alterations that we may see within a thyroid nodule? Dr. Bandula, Dr. Lagreca. I don't know if there are any studies, but yeah,
I'm not aware of any study that had been published about it. I don't know if you have any other.
Yeah, likewise. I'm not aware of any on a molecular basis. You can think about, the very aggressive like anaplastics or poorly differentiated thyroid carcinomas where, perhaps immune checkpoint inhibitor therapy might be an option. So if there might be an alteration of the immune landscape, that could be, hypothesized from other chemotherapy treatment or other treatments for other cancers. But I think that relatively speaking, I think that the genomics of thyroid cancers are a little bit more kind of straightforward and stable, say, compared to lung cancer or other, complex cancers. And so again, I'm not really aware of any known genomic alterations secondary to other systemic treatments for cancer.
All right. Well, I'd like to thank you very, very much for your time and for being with us virtually today. Hopefully in future meetings, we can all be together in person. And yeah, we look forward to future discussions. So with that, we will be ending our session on thyroid nodules. Thank you.
Thank you.
Thank you.